So I think, in my opinion anyway, it's fair to say that nearly all psychotherapists around the world started tapping into a psychotherapy integrationist mindset as a result of the pandemic. So that's sort of one of those very unexpected consequences of a terrible experience. And I say that because I started noticing psychotherapists reaching out to one another to really grapple with and think deeply about issues of how to establish therapeutic presence with their clients, despite the fact that they were physically distanced. And so there was a strong elevation of attention and consideration and underscoring of the importance and the foundational nature that common factors play in good quality care with patients. So it really seemed to be a moment where psychotherapy integration, even among people who didn't know they were talking about it, was really in the limelight. So that really got me thinking about, well, where is this going to go? Is psychotherapy integration going to stay on people's radar, or will it drift? And will we kind of go back to whatever we were doing before? And as I started kind of having that fantasy exercise, I realized that once we had all the technical issues aside from what platform to use and how to modify our treatment consents and our privacy practices, that really what needed to happen during this period of physical distancing is to turn our collective attention to making sure that these new practices we were engaging in were grounded as much as we possibly could on a really solid evidence base. So that sent me into the literature myself, trying to figure out where is the evidence base for all of this new telepsychotherapy that we're doing. And in those early days of the pandemic, I found it hard to navigate that literature. And keep in mind, I'm an academician, so I've got wonderful resources right at my fingertips to be able to access the best literature of the world. And yet I found it difficult. It was hard to identify a centralized kind of way of indexing those. They were being published very diffusely across the literature. They varied wildly in quality and scope. And so to me, it seemed a moment for JPI to really kind of step in and provide an opportunity to create a curated collection of high quality evidence-based resources that were timely to help guide this new era of telepsychotherapy practice during the pandemic. Now I want to just talk about JPI for just a moment to say that JPI is strongly committed to providing high quality peer review, and it's an international journal with worldwide reach, and that predates the pandemic. But it's important context because it speaks to why, when I saw a pandemic situation, I felt JPI was really kind of uniquely suited to address that. So JPI offers the titles and abstracts in 3 languages and has a commitment to international welfare by participating in the World Health Organization's HANARI program. So if you're not familiar with it, the HANARI program makes full text articles available at no cost or low cost to thousands of local nonprofit institutions in more than 120 low-income countries around the world. So because of that, authors, when they're publishing in JPI, they're asked to really pay attention to their abstract in particular, with awareness that for some individuals, that may be the only thing they get to read. But for other individuals in these developing nations, they may get access to the full text, and so they need to contextualize their work with global reach and the international implications. So that's sort of just a manner of how JPI normally works. And so all of that was carried with it into the background of being well positioned to take on this special issue. If it weren't for the dire circumstances that led to the formulation of the issue, the panel we have today would just be riveting because it's a cross-pollination of ideas opportunity. And so it's sort of a bittersweet moment to get to have this experience, but knowing that it's coming from such a place of sadness and distress. For those of you who this webinar whets your appetite and you want to see the full issue, I have really good news around that the special issue was published this month. It's called Telepsychotherapy in the Age of COVID-19, just like the webinar title, so it makes it easy for you to find it. And it's for those of you who are SEPI members, you'll get it free. You get the JPI as a member benefit. But for those of you who are not yet members of SEPI, you can access it directly from the Journal of Psychotherapy Integrations homepage. So you can just enter the title of the journal in your browser and get to the journal homepage, and you'll find a tab there for special issues. When you click on the special issue tab, you'll see this one come up, and this is the exciting part. Every article in this issue is open access for free until October 1st. So I really want to give huge kudos to SEPI and to our publisher, APA, the American Psychological Association, for working together in record speed to get this issue to production and to make it freely available to address this public health crisis. Okay, so just turning our attention to these panelists today, it was a fun luxury to get to pick 3 papers to focus on. And all of the papers are excellent, but I wanted to give you a sampling of the wide range that's being published and the diversity of ideas and foci that you can find in this special issue. So invited these 3 author representatives from their groups, and I'll let them introduce themselves more. But I just want to, before I turn it over, I want to tell you that I just can't let go of my editor mindset. So when I'm working on JPI, I really view myself as being your eyes. And so I think as a reader, and I read each submission with the thought of, if I was a reader, what do I want to read in this journal? Well, today I get to be your ears. So Tracy is going to help me be your voice and listen to the panelists with the interest that you have in the audience. And so we really want this to be stimulating and engaging. So use us as your instruments. Go ahead and enter things into the Q&A for us, and the panelists are prepared to let us interrupt them and ask more questions. And I want to encourage the panelists to do the same, to talk to one another and help us see this cross-pollination possibility. So we have 3 authors with us today. I'm going to let you introduce yourselves. If you wouldn't mind telling us a little bit about yourself and where you're from before you get into your paper, that would be really great. But we're going to start with Dr. Wade. And so, Shari, go ahead and take it on.
Hi, everyone. I'm Shari Wade, and I'm a pediatric psychologist at Cincinnati Children's Hospital. And I've been working in rehabilitation medicine for most of my career. And my focus has been telehealth long before that was a thing. And so when this special issue came up, it offered a unique opportunity for me to really share the experiences that we've had over 20 years and multiple studies working with children with neurological conditions using telehealth, telepsychotherapies. So I'm going to share my screen. Before I do that, first of all, I want to thank all of you. We put this paper together with an international team of psychologists, neuropsychologists, and one neurologist, and we were meeting at 8 a.m. in the morning, which was 8 a.m. my time, Eastern Daylight Time. It was 1 in the UK, it was 2 p.m. in Italy, and it was midnight in New Zealand. So for those of you who are joining from Turkey and Portugal, I appreciate you being here so late in the evening. I also want to say that I welcome your comments and questions as we go through, because I don't have the most dynamic slides, but I think I have some things that I'm looking forward to sharing with you. So as I said, this was an international team that worked with me when we saw this call. As I said, I think it was a unique opportunity. And so in addition to myself and my graduate students, Lisa, Ali, Emily, we had Anna Adlam and Jenny Lyman at the University of Exeter in the United Kingdom, Alessandra Bardoni and Claudia Corti at Eugenio Medio in northern Italy, my colleague Avni Modi at Cincinnati Children's, and Trish Williams at Sick Kids in Toronto. So because this is a research presentation, I don't have financial disclosures to discuss, but I do want to acknowledge the funding support. So the current project was, and this paper was supported by the Patient-Centered Outcomes Research Institute, but the prior work was supported by the National Institutes of Mental Health, Centers for Disease Control, the National Institute on Disability and Rehabilitation Research, and the National Health Service in the UK. So what I want to do is talk a little bit about why I started doing telepsychotherapy with children with neurological conditions back around the year 2000, because it wasn't on most people's radar. And then I'm going to share with you some key take-home points from the research that we've done over the years from the perspectives of the data, the family feedback, and what therapists had to say, and then talk a little bit of the implications for clinical practice and how we can bridge that gap between research and provision of clinical care. As Jennifer said, you know, suddenly everybody was thrust overnight to doing telepsychotherapy. And we had been doing it for 20 years, but who's going to find my studies? Who's going to read it? There's that huge gulf gap between what we do in research and then what gets translated to clinical care. So I don't know whether there are any pediatric psychologists out there, but children with neurological conditions they're a complicated group. So they have problems with attention, they have problems with working memory, they have problems with executive functioning, self-regulation, they have problems with social relationships. So they wouldn't be the logical candidate for a pilot of telepsychotherapy, right? You're always saying, oh, we need these high-functioning upper middle class people to do the work with. But we started with children and adolescents who had impairments in attention and self-regulation, and were able to do this successfully. So I'm putting that out there up front, just so you know that it can be effective with challenging populations. So one of the reasons that I went to telepsychotherapy from before it was a thing was because of the children who have behavioral issues following traumatic brain injury. And that's somewhere between 30 and 50%. Of those, only about a fifth actually receive any treatment for it. So the vast majority aren't receiving services, and there's lots of reasons why that's the case, but part of it is being able to access services. So people are treated in a regional hospital. They come from all over the place to receive trauma and critical care, and then they go back to their home communities where they may not know how to manage the consequences of brain injury or other neurological conditions. There's other things like stigma, transportation, and those kinds of things. So it seemed like doing things via telehealth would be a way to improve access. Over the years, we've really developed and piloted two different developmentally tailored interventions. So online family problem solving, we originally piloted and trialed with a fairly broad age range of children, but perhaps not surprisingly, we found that it worked best for adolescents because problem solving provides both a coping skill for the entire family to use to kind of address the diverse challenges they face following a child's traumatic injury, but it also provides an executive function heuristic for the injured adolescent. Both of the programs that we piloted over the years were multi-component. So we took advantage of the internet to have online modules that families completed independently. And this gave us the opportunity to share videos, to share interactive exercises, to share didactic information, and to provide things in a multimedia format. That was followed up by synchronous video conferences in which families could practice the skills and implement the problem-solving process with the issues they identified. So it was a very structured, but also tailored to the problems that individual families were raising. The parenting skills program that we've tested was based on parent-child interaction therapy, but again, we did things a little bit differently. We had online modules that showed parents both positive and not so positive ways of interacting with their child. provided information about the effects of brain injury on behavior and on families. And then we actually did live coaching via the internet using an earpiece, Bluetooth technology. And what I have to say is when we started, this was long before Zoom or Skype or even its progenitors. So we had purchased cameras. We also, because we were fortunate to have research funding, gave internet access and computers to all of the participating families, which meant that it wasn't limited by somebody's financial resources or the technology that we had at home. If they were able to have internet in their neighborhood, which again, if we go back to 15 or 20 years, that wasn't always the case, then they were able to participate. And so we had a range of technology users, from people who were complete novices, had never used computers in their life, to people who were fairly proficient. But even our most upper class family, a family of lawyers, their 15-year-old son said, "This is like James Bond," because that was back in the day. And you know, you can think about how far we've come in that time. So my message in the paper and also as part of this webinar is that I think that based on 12 trials over 20 years, I think telepsychotherapy can meet the needs of children with neurological conditions. I'm going to pause for a second.
Jump in with a question.
Sure.
I was wondering, you talked about the barriers with parents or with kids that you were able to overcome, and I'm curious about the institutional barriers. So 15 years ago, what did, I don't know if you were at Cincinnati Children's then, but, what did the institution think about this, which I'm sure was a really novel idea at the time?
So, I mean, I think people were open to it. I mean, I think that the institution was always pretty open. I mean, I think at various times, individual participants have had concerns about having their identity stolen and other things. And so, I mean, there were obviously some anxieties about technology. And I would say consistently that there's probably about 5 or 10% of people who really don't like technology. It's not a good mode for them. And we saw that in the beginning, but what's interesting is that percentage never shifted. So we took non-users and brought them in, and they felt empowered and they learned these skills. But there were other people, like even today in 2020, who will just be, I don't want to do that, but the institution was always very supportive and I think open to that. And to be very honest, part of what pushed me in that way is that the program officer at NICHD said, I think this would be much more interesting if you did it as telepsychotherapy. And I said, oh, okay, we can try that. I had never done it before, but I was open to trying it and, have had an opportunity to learn a lot over the years. So we, as I said, we've done 12 trials over approximately 20 years. We started out with traumatic brain injury, but we've also moved on to other neurological conditions, including pediatric brain tumors, perinatal conditions like perinatal stroke or congenital heart disease, epilepsy. We have documented over probably around 40 papers improvements in the child's behavior, both externalizing executive dysfunction kinds of behaviors, but also internalizing behaviors, everyday functioning. We've also shown improvements in caregiver depression and distress. And one of the things that's been really important for me is that we've actually documented greater effects among caregivers of lower socioeconomic status. So again, I mean, I think there's the assumption that this is something for people who are familiar with technology, who are doing Zoom calls all the time. And what our data showed is that if you work with and give access to people with lower socioeconomic status, it's actually even more beneficial for them. The other thing that we found over the years was really high levels of satisfaction from both the patients and families as well as the therapists. And so the feedback, going back to my comment to Tracy a moment ago, I mean, there was always about 5 or 10% of people who didn't like the approach, who didn't find it helpful, but by far and large, most people really embraced it and really found it helpful. So some of the advantages, and I don't have any polls for you, but if you're doing telepsychotherapy, I'd be curious if whether you've experienced these advantages or what advantages you found in your own work. So feel free to kind of put that into the Q&A and Tracy can share it. But one of the things that the therapists that worked with me over the last couple of decades really talked about is you're meeting families where they are and you have tremendous ecological validity. So families pull it together, they come to your office and often hold it together for the 45 or 50 minutes of the session, but you don't see how they live. And when you do something like this, you are seeing how I live, and you're probably hearing my dogs in the background, and I apologize for that. Brownie's very sad he's not in the office with me. And so you get a feel of the family dynamics and what's really going on. And that helps build rapport. And we found higher levels of rapport in the therapist-guided online, so sort of like what we're doing now, versus traditional face-to-face, because you're actually in the home with the family. The way that we did it, because we had the website as well, it also allowed families an opportunity to engage in different modes of learning. So they could watch videos of other survivors talk about how their brain injury affected them. They could do interactive exercises. You could share your screen, although that was a little bit more primitive back in the old day. And they could track their progress and monitor things online. So from a patient and family perspective, this is some of the actual quotes, and we have a lot of quotes over the years, but one of the adolescents in the problem-solving group said, "My general experience with the project was amazing. I really felt like it was a huge part in helping me understand my injury and helping me cope with the side effects." In the parenting skills program, one of the families, and this is one of the families from Toronto, so a more recent family, said, "We were lost before this program. So we were frustrated and we had taken it out on our child, unfortunately, learning that it might not be his fault because of his brain injury has definitely made a difference in our relationship." And we heard that consistently. One family that I worked with said, "You saved our family." So I guess what I'm saying is that telepsychotherapy can be just as powerful and just as effective with a population that you wouldn't put your money on. If you said, what's the ideal population to do it with? You wouldn't say children and adolescents with neurological conditions. So I think it just speaks to the power of the approach. From the therapist perspectives, and a few years ago, I went back and interviewed all the therapists who worked on the various projects. You have another question, Tracy?
Yes, we have a question from Emmanuel in the Philippines. And he is wondering, how did you go about dealing with ethics issues? I think there are challenges in terms of dealing with children using technology that reflects my observation in the context of my country, the Philippines.
So a couple of things. These were family-centered programs, so we did not have children using technology alone. They were using it with their families. Early on, we did try to put some parental, like blockers on, because we were giving them technology. So when you give people technology who didn't have it before, I did have concerns about pornography and other things, and we put blockers on. And over time, as technology has become more pervasive, and now most people have technology either on their smartphone or somewhere else, we haven't done that as much. But that was part of the informed consent and kind of the discussion about boundaries and potential scams and phishing. So again, giving technology to naive technology users, we actually did give people a whole manual, and by a manual, I mean a few pages of, okay, there can be scams, there can be this, there can be that, and these are things you need to watch out for. So we did a little bit of that. So as I was saying before the question, back in 2017, I interviewed all the therapists who had worked on the project to date, and we published that in the journal Rehabilitation Psychology. But they had, really found the telepsychotherapy approach equivalent or superior to face-to-face treatment in most respects. And one of the women who worked on the project when she was a graduate student and had gone on to become a neuropsychologist said that she was using it in her private practice, even though she wasn't reimbursed, insurance wouldn't reimburse, but families liked it so much that they would pay out of pocket. And she liked it, so she had set up her practice that way. So not only did they feel like it was an effective approach, they had carried it into their subsequent practice, even though it at that point wasn't being reimbursed for insurance. I think one of the key learnings for everybody was the importance of establishing boundaries and setting families up for success. So we learned tons early on. And again, for those of you who've done this for the first time in the last few months, you learn that you need to talk with people about the boundaries, that this is going to be a session the same as we do in the office. You should come in. If you're going to have a glass of water or a snack, bring it. Everybody's going to be there. You're going to contract to be there for the time. And so really establishing those boundaries, who's going to be there and who's not going to be there, and thinking about how to handle crises in advance. And interestingly, again, in the 20 years, we didn't have any big crises. I mean, we worked with teenagers with brain injuries, and so obviously sometimes there were arguments, there were disruptions, but it wasn't different from what you would have in your office. And so really thinking in advance of how you're going to handle that.
Shari, I think we may have an unstable connection with you right now. I don't know if others are having a hard time hearing. Maybe people can comment in the chat, or if they're having a hard time hearing Shari Wade. Maybe
yes. So this is Jennifer. Yeah, I think Shari's internet connection is not doing well. But in case you can hear us, Shari, I'm going to pose a question for you to think about from Elizabeth. She's asking, what are some of the challenges and or disadvantages you found in telepsychotherapy?
Some of the challenges and disadvantages. So I think one of the challenges is establishing those boundaries. I think that is. Sorry about that. I've done a bunch of things, and usually do a pretty. So that right there is one of the challenges, by the way. So one of the challenges is issues with connectivity. and having a plan for what happens if you lose somebody. And back in the old days, that happened much more often. So making sure you have phone numbers. Sometimes we would do the audio by phone and the visual by whatever video conferencing platform we were using. So that's one thing. I think having that sense of flexibility. So we were doing problem-solving interventions, and troubleshooting technology issues became an opportunity to model some of those skills. So taking some deep breaths, stopping and thinking, kind of working through things systematically and troubleshooting. And sometimes calls were ended or canceled just because you couldn't get it to work. So, but kind of, I think that's probably the biggest disadvantage. For some children who are really inattentive or have very low initiative, so they're kind of very flat and withdrawn, I think the video conferencing can create an additional barrier. I think that can be worked through, and we had one person who was very dysregulated, didn't want to appear on video. He was, I think, 17 at the time. So he would scooch his chair out of the video and kind of participate, but he would have never come in and participated in the office. So actually it was an opportunity to engage somebody in treatment who probably otherwise wouldn't engage. You know, and as I said, I think there are some people who just feel really uncomfortable with technology. So the other thing, and I think I'm probably taking up more than my time. As I mentioned, I've got one of the things we did during coronavirus, because I was concerned about my colleagues in Italy, we started having weekly calls, and that's kind of helped us to think about these issues together at a multinational level. There is a current trial of the problem-solving program in Italy now. My colleague in New Zealand has been trying to launch one there, and the parenting skills work is happening at Sick Kids in Toronto. So I think really thinking about together how can we bridge that gap between the research, some of which you know, as in my work, has had an opportunity to mature and really see it find its way into everyday clinical practice. So with that, I will stop, and I'm happy to answer questions later. And you can certainly always follow up with emails and other things later as well. I'm very happy to do that as well. And I'm trying to stop my share, so I'll do.
Dr. Wade, I can't thank you enough for sharing your work with us. For whatever reason, my video is showing my background, but not me. So I'm feeling a little out of body of experience here. But thankfully, I'm not the primary focus of attention at the moment anyway. I'm going to pitch this over to Dr. Bouchard, who's going to share his work with us.
Thank you. Share my screen. There it is. So thank you, everyone. I'm Stéphane Bouchard. I hold the Canada Research Chair in Clinical Cyberpsychology in Gatineau, Quebec, in the province of Quebec in Canada. And I've been doing video conference-based psychotherapy since 1999. And we're really glad our group was, the subject we submitted to the special issue was selected. And it's about telepsychotherapy for generalized anxiety disorder and its impact on the working alliance. So the relevance, I'll just close myself here. Okay. So the relevance of telepsychotherapy, as we discussed, we heard in the previous talk, it's been tested for several disorders. We're not going to focus this time on brain disorders, but on mental disorders such as anxiety, PTSD, depression, and so on. But it has never been tested for GAD, Generalized Anxiety Disorder. If you want an overview in the special issue, the paper by Bennett, which is in italics right here, has been quite interesting because it reviews a lot of the work. There's the most recent and previous lit reviews from Berry Hill, and I'm just pitching here some results that we got that are in press on our results on the clinical trial on panic disorder and agoraphobia, and it shows that using video conference to do psychotherapy is as effective as face-to-face, at least in this case for panic disorder. But the remaining question is that a sound working alliance is an essential component in psychotherapy. I'm doing CBT, and even part of CBT, it is a key essential component, but more data is definitely needed to document how it might be disrupted by video conference psychotherapy. So the goal of the study, the aim of the study is essentially to assess the impact of delivering CBT, cognitive behavioral therapy, for GAD in video conference or in face-to-face, and see the strength of the work, see its impact on the strength and the trajectory of the working alliance. And we wanted to pay attention to both the client's perspective and the psychotherapist's perspective, which is something that is too often neglected in literature. And we also wanted to measure the alliance at different time points during the therapy. Usually in my lab, we do pre, a third, and post-treatment assessment. But for that study, we did it every 2 sessions. So every 2 sessions would have a better mapping of the progress of what's going on with the working alliance. The details of the study are in the paper, so I'm just going to go over the essentials so you can follow the talk. But there's about 150 adults suffering from GAD, mostly women. That's typical of the population. The mean GAD severity on the ADIS is 5.5. The ADIS is the anxiety disorder interview schedule. It's a systematic, structured clinical interview, and you rate all the symptoms on 0 to 8, and you need a 4 to recognize the symptom as something clinically significant, and then you sum up all these 4 scores and you give a rating, and if it's 4, it's barely passing the cutoff range. If it's 3, it's not clinically severe enough, and 4 and above, it's clinically significant enough to merit the diagnostic of any anxiety disorder, GAD in this case. We also looked at comorbidity, and about half the sample in our study had a comorbid disorder, mostly panic disorder and agoraphobia, social anxiety, major depression. But essentially, we did not refuse patients or clients because they had a comorbid disorder. The only reason we would refuse someone is if that person cannot stand having therapy right now. A, because they're too intoxicated, delusional, or in manic episode to follow the therapy, or because they need emergency intervention. So even if they're suicidal, they would remain in the therapy unless they need to kill themselves. They want to kill themselves and need attention now. So highly comorbid, hopefully what we see in hospitals and private practices. So it was a 15-week treatment, manualized CBT treatment following Dugas et al. Protocol, which focuses on intolerance of uncertainty. And the working alliance was measured with the working alliance inventory, WAI. And we looked at total score of the long version. As I mentioned, we measured working alliance every 2 sessions from session 1 till the end of the treatment. Patients. Well, participants were randomly assigned to either 2 conditions. So randomly assigned to face-to-face or video conference based psychotherapy. Once randomized to video conference, we would randomize them again. So there were 5 sites participating in the study. I'm the Gatineau site, the leading site. So in Gatineau, if the patient is allocated randomly to face-to-face, where they're going to be treated in Gatineau. But if they're allocated to video conference, they're going to be allocated to one of the 4 other sites. So we picked up, again, random assignment to the other 4 sites that are the remote sites from where the patients are coming. It means that that allowed us to distribute evenly the impact or the potential impact of centers and psychotherapists. And all sites were linked with video conference unit. You see a picture here. And the client had to come. That's a big difference with the COVID-19 situation, and we're going to cover that in the discussion. but the clients had to come to the treatment site for the session. So face-to-face, they would come to the clinic. Video conference, they would come to the same clinic, but they would never see any of the staff. They'd see the therapist that is at the clinic at the other site. Look at the outcome first, and that slide is not on the paper, on the publication, because it's referenced in the paper. We need to know if the treatments work before we look at the alliance. It's nice to look at the alliance for any treatment, but it's more interesting to know if it worked. So the first graph is number of patients who met the diagnostic or who did not meet the diagnostic criteria at post-treatment. So success rate, GED-free patients who are not meeting the cutoff score. And you see roughly here that about 80 to 85% at post-treatment, at 6 months follow-up and a 12 months follow-up were considered clinically as not meeting the diagnostic criteria for GED.
We have a question for you.
Yeah, go ahead.
Nelson asks, did therapists and patients complete the working alliance inventory?
Yes.
Both. Okay.
Both of them. After every 2 sessions. Okay. So we looked at the success rate more globally. If you look at the success rate now on the scores of the ADIS, which is more refined. Pre-treatment to post, we see significant improvement from pre to post in both conditions. The blue line is the face-to-face. The red line is the one we are focusing on, video conference. It worked as well. Pre to post, post to 6 months and 12 months follow-up. So we have significant improvement. The gray line there is, as I mentioned earlier, the cutoff score. So they were above the cutoff score pre-treatment. They were all, or 90% of them were below the cutoff score at post-treatment. So we had a significant impact and the treatment did work. If you look at numbers, if you look at numbers, we can do it rapidly, but essentially the interaction, which would mean that the one treatment would be more or less effective than the other, is significantly, this is minimal. It's 0.0, it's 0.06, so it's really, really small. But what is more interesting is we did a non-inferiority test. That was, the grant was called upon to be a non-inferiority trial. So we can say with a really strict margin of confidence that it is statistically not significant. It's statistically significantly non-inferior. So it's just not that it doesn't show as being less inferior. We can say that it is essentially the same. So that's not part of the specific focus today, but we need to clarify that the treatment did work. So the results that are on a paper, if you look at the results, we're going to look at them over 3 slides. The first slide is the results of video conference versus face-to-face on the working alliance, but through the patient's or the client's perspective. So focusing on the question that was asked before, if you look at the 2 first lines on the top, the red are patients receiving psychotherapy in video conference, and the blue is receiving face-to-face. You see essentially that the treatment of the alliance was strong, and I need to insist on that, because if you look here, the minimum on the WAI is 36. So if you get score 1 on all the items, which mean totally poor, it's 36. And obviously it's not up to scale, but you can see that already on the first session, the alliance was really strong and really, really strong, close to the top. And that's fascinating. That replicates our previous studies on PTSD and panic. Essentially, second thing is, yes, question? Jennifer?
Yes, thank you. I was just wondering, did you see a difference between conditions in terms of dropout rate or willingness to come to the very first session?
No difference. Good point. No difference in dropout. I don't have the numbers right off my head, but there was about, I think there were 2 patients in each condition that worsened. That's something people usually don't look at, but it's important. And there's a dropout rate of about, I think, 10% in both conditions. But you can look at the papers, you'd see the numbers. Patients were willing because they knew they were coming to a randomized controlled trial on video conference-based psychotherapy. So that's, once they received the assignment, they were desperate to get treatment like most people in Canada. So second point, if you look essentially at the graph, there's a significant difference, and the red bar is significant, or the red line is significantly higher than the blue line. meaning that video conference in that study, the working alliance was significantly higher in the video conference than in face-to-face. So I insist it was higher. So we're happy with that, but it goes against so many therapists' fears that it would be less, it would, or at least would not be significant. Well, it's significantly better, so at least on the client perspective. And there was no interaction. If we aggregated the score and we just do a rough mean of everything, then it doesn't become significant. And essentially, if we do pair comparisons at each sessions, we see that what is driving the impact is a significant difference at session 15 and session 11. So if we find a difference between video conference and face-to-face, favoring video conference, it's probably because what's happening in session 11 and session 15 and not an overall effect. If we now change the lens and we look at, according to therapists, which is the other two lines, or a slightly different pattern of results, but essentially A, alliance was again strong, rated by therapists. B, there was no significant difference in face-to-face versus video conference. So video conference was never significantly lower, and it was actually sometimes higher, sometimes lower, but that never reached statistical significance. So we see that the results here are following essentially the same kind of line. Now, if we look at, if we compare the whole picture, and if we compare ratings of alliance by therapists and by clients, we see that clients rated working alliance as significantly higher on all occasions except on session 3. So overall, we can say that patients or clients are seeing their alliance with their therapist as better than their therapist would see it. And if you look at, you try to model the lines, what we found is a linear curve, a linear profile for the patients, the clients. So progressively, the alliance grew up progressively as it went from session to session. So it was not a flat curve, it was not a U curve, there was some discussion on the literature on what it would look like. We have a linear curve. But for therapists, just I finished that and I'm yours, Tracy. When we look at for the therapist, you see that it's a cubic curve. What it means is it swings from up and down and swapping up and down. So for therapists, it's not a flat line, it's an increase, but it's sometimes with little hoops and down. Yes, Tracy.
I have a question, which is that gap between therapist-rated working alliance and patient-rated or client-rated working alliance commonly found in the literature?
Very common. I'd say...
Very critical bunch, aren't we?
Yeah, and yes. And there's a question of who's right, actually. Mm-hmm. Because does my opinion matter more than the one of my patient? Because they are the one in therapy and they're the one getting engaged in the whole thing. But definitely it needs to be at least in sync somehow. Mm-hmm. So it is in sync, it's strong everywhere, it follows the same curve essentially, but therapists, we do kind of probably, I don't know, have higher standards or have a more broader range of expertise when we assess alliance compared to patients, for whom it's probably their only first or second therapy. In our case, it was their first therapy.
Thanks.
I just want to jump in a second and say that part of what I think is fun about this is it really reflects, as psychotherapists, how much concern we had about going to telepsychotherapy. And we were sure it was going to tank relationships. But I don't think our clients were ever nearly as concerned about that as we were.
You're right. And to push on that, if you look here on these sessions where we're doing exposures, so we were bringing these GED patients to think and reenact in their mind their worst case drama to face their fears. And the alliance was still strong and grew stronger. So even then, when we're pushing the envelope of having our client do something that is not really comfortable, the alliance hold and hold strong. So I'm going to look at the conclusion and bring the implication for the COVID-19. First, we found no evidence that working alliance is seriously disrupted when you use video conference. Actually, it's the opposite. I'm not rejoicing myself because working alliance is higher in face-to-face. I'm essentially happy because it was not lower. And I think that's the point. In our studies, it's the fifth one. It's the fifth clinical trial we do now that replicates the same thing, hammering it again and again and again. But at least for CBT, there's less studies for other approaches, and in that case for GED. Further research is needed to test the relationship between the working alliance and other key treatment outcomes mechanisms. For example, if the alliance is strong, does it help therapists and patients tend to do more relevant material that helps them, in their case, lead to change in intolerance of uncertainty? We have a paper on that, and the answer is yes, but it's a story to come. Now the difference between our study on the first slide and the other one, I don't know if it shows on the right or on the left on your monitor, but the first slide on the left for me is a copy of what happened in our lab. So you had the patient coming in an office, in a psychologist's office, the psychologist being in his or her office at the other side, and we were doing therapy. So we're not together, but we're in the same context, as opposed to what happened now where you'd see patients in the other image, where you'd see patients, it's either the therapist or the patient, but at home. And there are differences here that are discussed in the article, but I need to highlight that because I think that's the most fascinating interest. There are differences in terms of confidentiality of the location. We didn't have to worry about whether the room was soundproof or whether there'd be other people in the therapy when the patients were doing the session. It was a therapist's office, and the communication was secured, which is different now with the technology we're using, Zoom or either any one of them you use. Dr. Wade mentioned before this idea also of being in people's home. When they come to your clinic, well, they wait in a waiting room and then they're in your office. It changed the ballgame a little bit when we do video conference because we're somehow drawn in their homes. We see what their surroundings, their homes, their apartments, the way they live. So it has logistical issues like setting up the appointment. Dr. Wade mentioned some of it. And for some patients or some clients, it feels less formal. And they may be more at ease to interrupt you or not get as much engaged in therapy. And for some other, it's an asset because they feel less pressure and they're more open. So definitely there's a difference there that needs to be more studied. And there's this illusion of instant access to a therapist. They think that some patients or some clients think that they could actually send you a message and you're gonna pop up immediately as a therapist that could help them during the weekend, as opposed to when they come to your office, there's this implicit logistic issue of taking an appointment. Yes, Jennifer.
So we have a question from Elizabeth. She's asking, had the therapist met any of the participants in person before they started video conference therapy? And if not, do you think in general it makes a difference to have face-to-face encounters before you begin a psychotherapy process?
Interesting question in the context of COVID. That study was started long ago, long before COVID. So no, they never met, never, ever face-to-face. It changes a little bit when we look at COVID, where we do some therapy sessions either before face-to-face and now in video conference, or we started in video conference and we could switch to face-to-face. So it's a slightly different approach. I haven't seen any data on that because no one actually thought that that would be relevant to ask. And now it's a really significant question that you're asking. But to me, it's not an issue. Some clients prefer face-to-face, but they do video conference because they don't have any choice. Some others kind of like video conference or get used to it, and it's more practical and flexible for them. They don't have to spend time to commute and go to your office. So it's an open question so far, but I'll see that in the end of the last question, end of the last slide. We're going to discuss a little bit about that as well. But in terms of similarities, we had to cope with lags. Dr. Wade mentioned the same thing. Even we had a high-tech system, we had to cope with lags. And because of that, we used to take longer pauses. And my therapists were trained to try not to interrupt the patient and actually to use more thumbs up and nonverbal cues and say hi things like that or great or enjoy with their face, to use more nonverbal cues instead of cutting each other when we're talking. There's this issue of poor eye contact. If I want to look at you in the eyes in a video conference, I need to look at the camera, not at the screen. So if I do that, I don't see the patient or the client. So the issue of eye contact is the same whether the technology we use or not. And the importance of telepresence, and I hope you have more questions on that at the end, but this issue of telepresence to us is key. you forget that you are in different rooms, but you are in therapy with a patient. And we're actually present when you do psychotherapy face-to-face. When I see a client, I don't try to think, or where am I, which floor, what date, how's the weather outside. I'm just in therapy with the patient, and we do connect together, even though we're sitting face-to-face. Or if we're in video conference and we're working on emotionally relevant material, we do connect as well. And that's, at least for us, is a key variable. And as Dr. Wade mentioned, there's this idea of dealing with emergency situations. If you want to know more about the practical issues, I suggest the Van Deel article on the special issue is also interesting. Last slide before we go to the, before I'm done, there's also technological differences that I want to highlight and mention. This is an example of our system. And one of the reviewer asked us, or it's Dr. Callahan, but when we wrote the paper and during the review process, it was asked us to mention the technological difference, because in our system, you just have to use a remote control. You flip a switch and you have a menu of 5 sites. You click on it and you're in connection with the other site. So really low tech, as opposed to now, different software. So as a therapist, you need to be able to handle different softwares. And as a client, you might have to do the same. And also as a client, you need to be aware that this is an example from my FaceTime account where there's logs of all the calls I did. So as a patient, as a therapist, if I hand my iPad to my kids in the car so they play, they're gonna see all the numbers of all my patients and they could actually dial them. On the opposite, all the patients that have my number, if you use FaceTime, if you don't use FaceTime, there's other apps, but there's oftentimes the same problem of leaving traces that could lead to breach of confidentiality. And there's also tech similarities. There's unstable communication, we mentioned that. And there's also therapeutic techniques. For example, if we do exposure for social worries, and my patients have to learn to face ridicule, is not that threatening, well, you could do that in video conference and you could do the same. Sometimes people are worried that they would do emotionally challenging experiences with their patient because they're in video conference. That's what we did in our therapy sessions. Most of the therapy sessions were emotionally challenging, and we brought patients to, well, we listed emotion and helped patients to confront them and go over these emotions, even though we were at remote site. So we did more than just talking. It was experiential and frightening for the client, and they were still able to go over that with success. So I'm open for suggestions. I'm probably a few minutes behind, and I'm all yours.
Just one quick question. The findings you're reporting are fascinating and go counter to what many of us fear. You mentioned 5 replications in your lab. Do you find this replicated outside of your lab in other articles? And also, you gave some ideas of what's going on, but any other insights about why the working alliance was greater with the telehealth is appreciated. It's fascinating.
Thank you. I'll comment on replications, why, and then the why. Yes, it's been replicated. We did panic twice, PTSD with complex cases, and then we did social anxiety, and now it's GED. And it's kind of becoming a boring story because we know it's going to be, we know it's going to work, and we know the guidelines will be as strong as it's face-to-face. But we need to answer and reassure therapists for that. And it's also coming from other studies across the world. One of the methodological issue is that it's been challenged that not all of these studies are randomized. So, and that's a big problem when you do telehealth. If you do telehealth, and if I randomize my patient like we did here, the patients know that they're coming to a clinic when there's a psychiatrist or psychologist nearby, and that's reassuring. If it's not randomized, then it's much more realistic because patients are from really far remote locations. But then we don't have the randomization. So half of our studies are randomized, the other half is not. So, but it gives the same results at the same time. The biggest question, I think, well, the most relevant interest for us in our lab is the idea of telepresence. And the simple example I can give you is if you don't really like my talk, and I'm thinking to the audience, there are 89% now, if you don't really like the talk and barely paying attention, you're probably scribbling and looking and having a drink or watching outside, and your level of telepresence, you don't feel connected with me. That's fine. But if I tell you I want to kill myself and I'm ready to do it and I have a plan, I'm sure you're going to connect with me because you're a psychotherapist. We do that all the time. So the difference is when we're talking about boring stuff, we do easily dissociate and don't get present. When we're talking about emotionally relevant stuff, we do connect. And we do connect over the phone, and that's crisis lines. So the same thing with video conference. When we're working with emotionally challenging material, some of our experimental studies shows that when we're discussing emotionally relevant material, telepresence increases. When telepresence increases, it leads, and when telepresence increases, it leads to stronger alliance, and then stronger alliance leads to more change. So there's this kind of mechanism that is starting to be studied, at least in the field of psychotherapy. So Camilo, that's what I would suggest is the key for telepresence. We're emotional people that do easily connect with other people, especially if they're in dire needs.
So I want to build on that just a little bit by posing a question from Jackie. She wants to know, do you think therapy approach can make a difference? In teleconferencing, a lot of nonverbal communication can be off-screen, and it can be difficult to pick up on the emotional feel.
Yeah, there's the nonverbal and these other schools of approach. Usually most people, when they do Zoom, they will be like this if they're not like that, but they're really close to, and we miss part of the body. In our therapy sessions, we're a bit further than that. I just can't because the room is not large enough if I want a high, good Wi-Fi or connected. But usually I take the trunk up. So I need to be able to see my client. So I get some of their nonverbal expressions as well. And I can communicate mine, which I can't over the phone, which therapist nonverbal also matter. So yes, there's some elements there. And I just missed the other lead question was, there were 2 points. Would you just re-say the question, Jennifer?
About there's so much nonverbal stuff that happens off screen. Yeah. So I'm adding my verbal.
And the other approaches. There's a psychologist in France. Her name is Gleaned. She's referred in the paper. She's a psychoanalyst, and she's doing psychoanalytic psychotherapy in video conference in France. So we're working together on trying to tease out these elements. But there's not that many randomized control trial on alliance with other approaches, but there are. And most especially on psychodynamic psychotherapy from France, work at Duke. And she is co-author on the Van Dien paper. So there's some other stuff going on.
That's fantastic.
I just wanted to chime in with a thought about that. I do a lot of play therapy. And what we do is, I have a video on Vimeo about it. We tilt the screen way down and I sit on the rug. So my entire body is in view and all the toys. So it's an even like further out, wide lens. And we also just finished an RCT, a psychodynamic psychotherapy RCT during COVID. So we have a bunch of cases that we wound up moving to online when it was an in-person play therapy. Lots of interesting things from that.
And that's true with our work with families. So when we had a whole family, we would move it out further. And sometimes there were people out of the frame and that required some additional conversation. But in the parent-child positive parenting, we did the same thing. We set it up and we kind of created the boundary on the floor and had them position it so you could watch them playing and do that. I hear all the Legos clanging and stuff, but I mean, it is doable to capture more, and I think thinking those things through in advance are helpful in terms of what you're seeing and what you're communicating.
I want to make sure we have enough time for our last presenter. This was so great.
Thank you so much. Dr. Ruggero, can you make sure your camera and mic are turning on? We're going to switch to our last panelist. I hope our audience doesn't get whiplash from this webinar, that I was really wanting to capture the diversity of articles appearing in the special issue. But as I'm a participant, I'm realizing we're covering some really remarkable spread of territory here, which is what makes the issue exciting. But right now, I can feel the weight of the panelists thinking, where do I fit into this? So Dr. Ruggero, you're going to bring us a radically different perspective, and we're excited to hear about it. We're going to turn it over to you if you'll tell us a little bit about yourself and your team. I see pictures there. And give us an overview of your work, please.
All right, thanks. I'm Camilo Ruggero. I'm at the University of North Texas. And I almost regret presenting now because the discussion, I'd love to hear more about some really practical ideas for telepresence and all the great experience of Shari and Stéphane. So it's a little bit, but anyway, we'll continue with this presentation, but I'd love to hear more from the other panelists about their work. So let me just briefly talk about or the article that we had submitted. Let me give acknowledgments to Charles Bennett. He's a graduate student who really did the lion's work of this review. We did a review of reviews and meta-analyses. As well as Lamia Yanori, who's a grad student who's focused on health disparities, and Mariah, who's an undergrad who tests out all sorts of eHealth interventions for us lately. So kudos to them. I also want to acknowledge the Texas Higher Education Coordinating Board, as well as HRSA for funding some of this work. I'm at the University of North Texas, as I mentioned. We're part of the DFW Metro. Our team has no conflicts of interest. We're not making any money off anything we're going to talk about today. So basically today, what I briefly sort of want to go over with you guys is some of the barriers to accessing psychotherapy. This talk is radically different from the previous two. Jennifer, you absolutely read my mind. What we were focusing on is COVID is a new kind of barrier for people getting psychotherapy. But there are so many old barriers that have not been addressed. So I'll talk a little bit about that. Talk about eHealth, a broad, too broad maybe term here, as an alternative. And what the bulk of our paper is really about the evidence. And I want to talk a little bit about the evidence of what we found. So starting out with barriers, both new and old, as many of you know, clients have had health prescriptions have made it really hard to go get psychotherapy now. And telepsychotherapy with presence has been discussed, is clearly one solution to that. But there's so many other previous barriers that exist to getting psychotherapy. And all of you on the call know this, so I won't belabor it, but mental health problems are ubiquitous. 1 billion people, globally, service rates vary widely from country to country. In my own country, I know that this is an international call, but in my own country, here's a map of the United States that Jennifer had shared with me before. Each dot represents a person. Half those dots on that map at some point in their lifetime are going to have some disorder, if you believe, for example, the National Comorbidity Survey, Community Survey that Kessler done a while back. We know that in any given year, 50 million people in a country of 330 million people in the United States have a disorder. We know that rates of mental illness are rising. This is stuff that I think most people on this call appreciate. We also know that business as usual is not okay. COVID represents a traumatic disruption of services and delivery of psychotherapy. But even before COVID, in SAMHSA surveys, 20% of folks are reporting unmet mental health needs. 11 million people of that 48 million are saying, I didn't get the care that I think I needed in this past year. And the overwhelming reason for that is cost. So these are numbers that I'm sure they're similar in other countries, maybe worse in some than others. The American Psychological Association commissioned a report a couple years ago, looking at the shortage in the workforce, the psychological workforce. And what they found there was that if that first row, if the uninsured got the same level of care that the insured got, we would need 5,000 more psychologists. And I'm speaking from my own perspective as a clinical psychologist. We need 5,000 more psychologists than what we have currently. We currently have, when this was done, roughly 100,000 psychologists in the country, in the United States. If we tried to meet the unmet healthcare needs, we'd need 20,000 more psychologists. So there's clearly a shortage. Now, obviously, psychologists aren't the only ones providing services. Primary care doctors provide the bulk of it. But there's clearly some unmet needs that, that also vary by who gets access to psychotherapy. And this is one of the issues that we've really been focused on at my university and my department, is that not all races, ethnicities get the same level of care as, for example, non-Hispanic whites in the United States. If we were to give all races, ethnicities the same level of care as non-Hispanic whites, we would need 20,000 more clinical psychologists to fit that need. So clearly, who's getting care is not the same there's a lack of care for many people, and who's getting care is also, there's some disparity there. All right, so that's a pretext that I'm sure many of you on this call are familiar with. There are lots of ways to solve this. Yesterday I was talking with a clinical psychologist at the University of Houston who really thinks, we need to partner more with people in social work, for example, who deliver therapy as effectively, but it costs less to train them, to really, do more interprofessional training to solve this problem of, barriers to access. We've been looking at eHealth as one potential solution to that. And eHealth, we're thinking about automated psychotherapy. So things like, and I'll give you a couple examples in a minute, And at a population level, there's really obvious reasons why you might want to do this. It's cheaper than training a bunch of therapists, and you can do it at enormous scale. As an individual psychologist or psychotherapist who might be on the call, there are lots of reasons you might want to consider it. COVID-19 means you may have had to close your practice. You need to offer something. Oftentimes, clients show up, and I think the rates that I last saw, 50% don't show up for a second session. So there are clients that, for whatever reason, don't want or can't access psychotherapy. Clinics often have wait lists. I think we have a poll just to make this a little more interactive. I don't know, Tracy, if you want to shoot that poll out to everyone or not. Well, while she's doing that, let me give you some examples of some of the eHealth interventions that we're talking about. There we go. Does your psychotherapy practice have a wait list? I'm just kind of curious. And we'll see what people say. So some of the examples of some of the eHealth interventions that I'm talking about, I'll just give you a few examples. My Compass, this, for example, is one out of Australia. It's free. It has different sessions that your clients can do. They register. It is, I believe, based on cognitive behavioral principles. It has little videos that help you. This is an example of a sort of standalone that delivers some of the benefit of psychotherapy in a way that's more automated. We also have, for example, the VA. Many of you are probably familiar with the PTSD coach, and results from the poll came back, and it sounds like many of you, 38%, do have some sort of wait list at your clinic. So these are examples of things that in stepped care models you might offer when people are waiting for services, for example. So that might be one of the benefits here. So another example is PTSD Coach, which is not a treatment per se, but it's one that's free and offers, I think, some relaxation exercise, allows people to track their mood, for example. A couple of other examples, let's see, there we go. Mood Gym is one that's not free. This one costs $27 a year. So relatively cheap, but involves cognitive behavioral principles and for treatment of depression and other disorders. So, sorry, okay. So there are many out there, and it's important to realize, as many of you know, that the vast majority of eHealth interventions like this out there have zero evidence for their efficacy. There's a companion, not a companion, but there's another article in this issue that looked at the most popular apps being downloaded for mental health. And of the 20 or 25 that they looked at, most of them, 20 of the 25, something like that, had no evidence to support, whether they're effective or not. So this is the Wild West right now, and in terms of apps that are out there, and very little have evidence. What we're interested in is, what about this general approach? So we sort of did a bird's eye view of this, and we looked at what's the evidence for their efficacy. So we did a search for all types of mental health apps, not just apps, but websites that have automated different elements of psychotherapy. And just to cut to the chase, we ended up looking at 37 meta-analyses and 28 reviews that had targeted 4 outcomes: depression, anxiety, substance use, and general well-being. I'm not going to go over all of them today. There's just not time, but I'll focus on depression, which is the most common. Our article has a great reference in this table where we outlined all the different meta-analyses we looked at, what they were based on, and the effect sizes you can find there. So it's a wonderful reference if you're looking for more details. The most common interventions that we reviewed, they were web and app-based interventions. Half of them roughly were guided. In other words, they had some sort of clinician involvement in it. Many of them were unguided. They were just sort of standalone, or no guidance was provided. The samples and across these many different meta-analyses were community, clinical, many undergraduate studies looking at this. And the control group was most often a waitlist control. So, so this is not compared to some sort of placebo, but rather to a waitlist control. Well, how well do they work for depression? So let me just get to the main sort of finding of what we found across these multiple meta-analyses. And I think it's important to understand, a point of comparison when we look at an effect size. What does it mean? And if you remember from your bad old days in grad school, effect sizes, we talk about Cohen's D is probably the most popular that most of you guys remember. And there are rules of thumb: 0.2 is small, 0.5 is moderate, 0.8 is large. We know that published literature tends to overstate effect sizes. So these are just rules of thumb when you think about how effective are these. Better, I think, to think about other types of modalities and how well those do. So when we look at a meta-analysis of 28 studies of CBT versus waitlist, the effect size there, G and D are essentially similar. You can think of it as cones D. You see very large effect size, 0.98. CBT versus placebo in 5 studies that were part of that meta-analysis, you find a moderate effect size, okay? When you look at just psychotherapy across different types of psychotherapy versus control groups, you find moderate, small to moderate effect sizes typically. And when you look at antidepressants, how effective are those compared to, say, a placebo? You find moderate, small to moderate effects. This is across 522 studies in the meta-analysis. So those are kind of benchmarks for you to think about what I'm about to present. How effective are these eHealth interventions compared to things that we know work or work sort of well? And I should say that we know placebos have an effect. So if this were compared to waitlist, I'm sure that 0.30 would be much bigger. We know treatments, for example, these are for depression, work. So what did we find? Well, we looked at 5 reviews and 17 meta-analyses. I'm going to focus mostly on the meta-analyses. Most of the eHealth interventions we found were based, the most common was based on cognitive behavioral therapy, but there were others based on ACT, based on behavioral activation. There were many different types, but CBT was by far the most common adaptation to these eHealth interventions. And what did we find? Well, across 17 meta-analyses, what we found was that the effect sizes, the average effect size in the meta-analysis were anywhere from small to quite large. The median was a moderate effect size. Now, this is compared to waitlist, so that's important. So most effects are small or medium. The effects tended to last up to 6 months. The effects were there for adults, but several of the meta-analyses included children and adolescents. Not surprisingly, when you assist with depression, there's improvements in all these other domains like quality of life, problem-solving skills, anxiety, well-being. Whether guided versus unguided matter, the evidence was mixed. 2 meta-analyses that looked at this issue found no difference. 3 found that guided was superior. So really what that tells me is that relationships tend to matter. The more there's a clinician involved in helping someone walk through that eHealth, and that can even be a minor sort of contact, you tended to have larger effects. There was no difference in terms of psychological approach. And again, most of these were CBT, but psychological approach in the studies that looked at that didn't seem to have an effect. What were some of the superior effects? Well, pacing seemed to matter. To cut to the chase, essentially shorter sessions, but drawn out over a longer period of time, tended to have higher effects than cramming them all into 1 week or overburdening clients with these. Reminders absolutely helped. Doing these as adjunct to medications helped. And then newer eHealth trials had bigger effects than older trials. Okay. So what about using these kind of approaches as an adjunct to your current psychotherapy? We looked at there was one meta-analysis. It was a larger meta-analysis, but 10 of the studies in that meta-analysis had compared treatment to no treatment with eHealth. And what you find in that is that these eHealth interventions boost the therapy. They provide this small adjunctive benefit in addition to what the therapy was providing. So all indications are that this is an approach that is not a panacea, is not as good as face-to-face psychotherapy or medications, but that absolutely is better than having people sit in a wait list waiting for your services, or for people who can't ever get into your door, which unfortunately is quite a large segment of the population. Attrition continues to be a big problem with these kind of interventions. And across 5 meta-analyses that looked at this, attrition rates range anywhere from 1/4 to 60% attrition. So attrition is a big deal. On the other hand, attrition is no different than a wait list. So if your comparison is a wait list, having any attrition, any benefit might be good. Obviously, guided ones had better effects than unguided ones. Acceptability seemed to be high. There were no issues. Most studies didn't consider safety issues. And in the interest of time, I'm going to speed up a little bit and just get to some of the clinical takeaways really quickly so we can have more conversation. So first of all, the major takeaway is that eHealth is a viable pathway to redressing some of the barriers to access. It's cheap. You can do it at scale, massive scale if you want, and it can be adjunctive. So if you're, this is coming, and I would encourage clinicians to think about how can you adapt this into your practice if you're not currently doing it. It's relatively cheap, and it's clear that it provides benefits. If you have wait lists for the clients who, for one reason or another, never come into your office, this can provide at least some benefit. Relationships still matter. The therapeutic relationship matters. Attrition, for example, was clearly susceptible to whether someone was involved in administering that eHealth. If this is entirely standalone, we find the attrition rates go up. It's important to note it's generally not as effective as psychotherapy or medication, but better than wait lists. And there's limitations, unknown safety concerns. For example, my biggest concern is that someone doing an eHealth intervention might think it's enough and never go on to get, face-to-face or telepsychotherapy with their clinician or medications from a psychiatrist. So that's my biggest safety concern. Are there some sort of unintended consequences there? And then another big one is that most of these apps, are the ones we've been looking at least, are in English. We know very little about culture or population-specific adaptations, and my suspicion is the field isn't there. Okay, in the interest of time, I went kind of quickly. I hope not too quickly. We can find our journal article there, and encourage you to email me with any questions.
Okay, so Camilo, I think you get the award for being the fastest talker of the day. So thank you. I know you are watching the clock and really trying to make sure.
Sorry.
No, I really appreciate you leaving us a few minutes so that folks can ask some of their last questions. One of the things that came to my mind in hearing you talk about it was I was sort of feeling the press. I said I was going to try and be the ears of the audience, and I was feeling the press of hearing you say this could be really effective as an adjunctive component of treatment, or for managing a wait list, or for working with somebody whose health benefits have lapsed for a period of time and they need to discontinue sessions for a period of time, those sorts of issues. But then I started feeling the weight of trying to understand, you said there's thousands of these. And so the idea of trying to have the responsibility for kind of vetting and knowing which ones to recommend or not recommend felt really heavy. And so I want to just point to people that if you go to the special issue for JPI on this one, there's actually an article where they did a review of some of the most commonly downloaded apps. And they did kind of a consumer report style approach to it almost, so that you can sort of see some of those. Now that won't be current in 5 years, but it'll help you this year. So you may want to take a look at that. I see we have something in the Q&A. So Nelson is asking, Camilo, were there differences between young and old patients using eHealth apps?
That is a great question. Most of the studies that we looked at did not look at young or old. Now, we looked at 65 different review articles. It was a tremendous amount. They're buried in there. I'm sure there's a moderator analysis. Off the top of my head, I don't remember, but it was not a commonly addressed question. So, so my suspicion is that there probably is some difference, but I couldn't tell you off the top of my head. And happy to email you with more specific information as I look.
All right, so I'm curious for our presenters if you have any questions for one another in our last few minutes. As you ponder that, Camilo, there's a question for you about the effect sizes, that they vary so much. Are these differences between apps?
Absolutely, and I think that's important not to lose sight. I was presenting just sort of the overarching bulk of evidence about the median and the means, but we know that there's tremendous variability, and even across meta-analyses, there's tremendous variability. The major takeaway is that there's evidence these work, but unfortunately, the burden is still on you as a clinician to understand whether the one you're using works. And clearly, some are duds and some are better. It's a good point that there's a lot of variability in how effective these are.
If I might add a comment on Camilo. Camilo, you just mentioned a second ago that, or a minute ago, that most of the stuff is in English. And we live in Quebec, Canada, everything is French, and across the river is Ottawa, it's in English. So that's an issue for us in our country because there's a paucity of apps available or good apps available in French. And because we have a worldwide audience today, any impressions, suggestions, because we need other languages, and translating is complicated because it's often proprietary because it belongs to companies.
Absolutely, and I think other countries, there are many. This field is evolving every month. It's a tremendously rapid, as all of you know, evolving field. It's a fascinating one. I'm sure in other countries they're developing them as quickly as in the U.S. and many other countries. But what's just I think that work needs to be done. But I think the tremendous opportunity that this represents, I think I want to just sort of settle on how this is really could be a very powerful way for us to deal with some of the millions and hundreds of tens of millions of people who never can go see one of the people on this call. And I don't know what everyone's personal responsibility is to those tens of millions of people who never get to see someone like on this call. But I think it's part of our obligation to the wider well-being of the communities we live in. So I don't have a great answer for you, Stephen. It's a great question, but absolutely needs to be done in different communities.
So Camilo, I've got one final question for you before we wrap up, and my screen's disappeared for this, but I think it was Gerald who was asking if you got any sense from the literature about what might be driving the attrition rate, because if this is a stopgap measure at times, and you can't bring them in,
yeah, people lose interest. It really, we saw over and over again in those that the amount of contact they had was a strong moderator of whether there was attrition. So having someone on the other end who knows and cares that you're doing this matters. And if you have no one on the other end who cares, and you're depressed, you're less likely to keep doing it. So I think that was the single variable that we saw over and over again.
I think we have to wrap up. This was such a great panel. I just want to thank everybody who participated. And Jennifer, thank you for organizing the panel. It's really
Thank you so much. This was my absolute pleasure. And thank you to the authors who were kind enough to not only write the papers, but then present it besides in record time. It's brilliant work.